Anushka?
Hello, am I audible?
Yes, you're on.
Can I have my slides, please? Good morning, respected judges and other dignitaries. It's an honor. I'll be talking on my paper, Dermoscopic Findings in Vitiligo, with special emphasis on disease activity and observational study in a tertiary care center. I have no conflict of interest and it has not been presented before. Next slide, please. Now, vitiligo, as we know, is an autoimmune disorder of pigmentation. There is loss of functional melanocytes and melanin from the epidermis. It affects around 0.3% to 1.1% of world population, irrespective of the gender and race. Now, normal skin has a reticulate pigmentary pattern, which is altered in vitiligo lesions. Dermatoscopic examination is useful in early diagnosis of vitiligo and to assess the disease activity. Next slide, please. Now, vitiligo causes significant cosmetic disfigurement. Though it is a benign disorder, it affects the psychosocial well-being of the patient. Now, there are many patches and many cases where they don't respond to medical therapy, in which surgical therapy offers a ray of hope. But stability is a very important criteria to opt for a surgical modality. So in that case, dermoscopy helps to understand the disease activity, to know the stage of the disease. And sometimes when there is a confusion about the diagnosis, it helps in that too. And dermoscopy being a non-invasive handy tool, it's way more useful and helpful. So it helps to understand the disease activity and the stage that we know, but there is a need to validate many reported dermoscopic findings for universal use. Next slide, please. Now, my aim was to observe the various dermatoscopic findings in vitiligo and to see the correlation of the findings with the disease activity. Next slide, please. Now, it was an institutional cross-sectional study. My sample size was 50 clinically diagnosed cases of vitiligo. Proper informed consent was taken, and then the inclusion criteria was checked. And then when the patients fit the inclusion criteria, detailed history was taken. Clinical and dermatological examination was done, and baseline data was collected in a pre-structured formula. Patients were divided into two groups. One was stable group and other one was unstable group, as per the clinical classification of disease activity based on disease stability issued by IADVL task force, which states that a patient reporting with no new lesions or no progression of existing lesions and absence of Kubner's phenomenon during past 1 year. The confidentiality of the patient was maintained. Dermatoscope DermLite DL4 was used to image the most recent vitiligo lesion as per the patient's history, and dermoscopic images were saved for the record purposes and further evaluation. Next slide, please. Now, my inclusion criteria was patient who have consented to participate in the study, patient of any age and sex, who are free from any systemic diseases, and patients with new vitiligo lesions, or patients who have not received any therapy for vitiligo in last 3 or more months. My exclusion criteria was any unwilling patient who were already on treatment, any history of malignancy or other causes of hypo and depigmentation. Next slide, please. So these were the 10 dermoscopic patterns which I have seen in my patients. Out of 50 patients, 15 were into stable vitiligo and 35 were in the unstable vitiligo group. Among all, marginal hyperpigmentation, perifollicular pigmentation within the patch or macule, and reticulate pigmentation with the patch or macule plus leukotrichia was observed more in the stable group, with percentages of 93.3%, 86.7%, 73.3%, and 66.7% respectively. Whereas trichome pattern, starburst pattern, comet tail, or also called as microcubnerization, polka dot pattern, which is also called confetti dot pattern, sago grain appearance or tapioca pearl appearance, and perifollicular depigmentation in perilesional skin and altered pigment pattern in perilesional skin were seen more in the unstable group. Now, 20% of stable vitiligo patients have shown altered pigment pattern in the perilesional skin, but all of them have shown reduced pigment pattern, not reverse pigment pattern. Whereas in my unstable vitiligo group, 34.28% has shown reduced all pigment pattern, whereas 28.57% have shown absent pigment pattern, which was different compared to studies, the previous studies which I have referred. They haven't mentioned anything about absent pigmentary network. And also comparing the study by Dr. A.K. Jha and Dr. Sontalia, he has said that in his study, he has noticed perifollicular pigmentation more in unstable group of 85% in the unstable group have shown perifollicular pigmentation, whereas only 10% in the stable group has shown perifollicular pigmentation in his study. On contrary to that, in my study, I have seen 86.7% of patients in stable group to show perifollicular pigmentation compared to the unstable group. Next slide, please. Now here is the graphical representation. The darker shade of gray represents the stable vitiligo patients, and we can see the marginal hyperpigmentation, polyfollicular pigmentation, reticulate pigmentation, and leukotrichia is more seen in the stable group, whereas the trichome pattern, starburst pattern, comet tail pattern, polka dot pattern, perifollicular depigmentation, and altered network pattern was more seen in the unstable group. Can I have the next slide, please? Next slide. And other findings which were observed other than the previously 10 mentioned findings were telangiectasia seen in around 8% of the patients, atrophy in 14% of the patient, and erythema in 6% of the patients. Next slide, please. So I have taken the pictures in polarized light mode, and all the percentages where I have used unpaired statistical test, and my p-value was less than 0.05. So first picture shows the marginal hyperpigmentation. The second one shows reticulate pigmentation in the vitiligo patch. If we see properly in the vitiligo patch, we can see minute net-like pigment patterns, which suggest stability. Then the third picture shows perifollicular pigmentation. We can see pigment around the follicles. Next slide, please. The first one shows trichome pattern. The innermost part is structureless, absent pigment network, followed by a boundary of tan colored, which is also called the reduced pigment pattern, then followed by the normal skin. And the second picture shows leukotrichia, white hair. And the third picture shows comet tail. If we can see 2 o'clock direction, there is a line-like thing, white color depigmentation, which is like called the microcubnarization. Most of the times it is due to trauma. Can I have the next slide, please? The first picture shows polka dot appearance. The second picture shows perifollicular depigmentation in the perilesional skin. If we can see most of the hair follicles at the base, we can see the minute depigmentation. And the third picture shows sunburst appearance, that is no sharp border is being seen. Can I have the next slide, please? The topmost picture shows telangiectasia. The middle one shows reduced pigment network in the perilesional skin. The third one, the rightmost one, shows atrophy with erythema. The lowermost picture shows negative pigment network in the perilesional skin. We can see white structures bordering centrally bordering the pigmented skin. Can I have the next slide, please? Now, the limitations of my study was the sample size was small and the study was done in a single center. And as the study was a cross-sectional type, follow-up was necessary to determine the long-term validation and finding the prognosis. Can I have the next slide? So in conclusion, marginal hyperpigmentation, perifollicular pigmentation, reticulate pigmentation, and leukotrichia are indicators of lesional stability, whereas trichome pattern, comet tail pattern, sunburst pattern, polka dot pattern, perifollicular depigmentation in a perilesional skin, and altered pigment pattern in the perilesional skin, especially the reversed pigment pattern, exclusively suggests disease activity, that is instability of the disease. Next slide, please. These were my references. Thank you, everyone.
Dr. Anushka, for a wonderful presentation. I would like to ask our judges if they wish to ask any questions to her.
Did you get any feature to differentiate vitiligo from post-inflammatory depigmentation or chemical vitiligo?
Sir, based on history, I could differentiate dermatoscopically. The trichome pattern, the sunburst pattern wasn't seen in post-inflammatory hypopigmentation, sir. And it is post-inflammatory hypopigmentation. So it is like hypopigmented on a long run, whereas for vitiligo, early lesions or evolving lesions might be hypopigmented, but gradually it becomes depigmented.
But there could be post-inflammatory depigmentation also.
Yes, sir.
So with it also, there are any, did you study this dermoscopy in post-inflammatory depigmentation to differentiate from vitiligo?
Sir, based on history, I have already ruled out. I have taken only clinically diagnosed patients of vitiligo, sir. So I have ruled out at the beginning itself any patients with post-inflammatory.
Now that is a separate issue. Any dermoscopic findings you got in post-inflammatory depigmentation? Have you studied it? Apart from vitiligo, I'm talking. Have done this dermoscopic findings that I'm wanting.
I have done in 1 or 2 patients, sir. I have not noted any trichome pattern. I have not noted comet tail pattern in them. I have not noted any reverse pigment pattern in them, and I have not noted leukotrichia in patients with post-inflammatory depigmentation.
And in chemical vitiligo, have you done in dermoscopic findings? No.
No, sir. Honestly speaking, I haven't done in
okay, thank you. Thank you.
Thank you, sir.
Yeah, Dr. Anushka, can you tell me how do you differentiate vitiligo from achromic nevus or nevus depigmentosis by dermoscopy?
Sir, there
because
are
a couple of your dermoscopic images would be
misunderstood with nevus depigmentosis and vitiligo. Sir, nevus depigmentosis, the pattern is in vitiligo. Most of the times we can see structureless stark white appearance. Nevus depigmentosis, it is most of the times it is hypopigmented, sir. It is not structureless white, like stark white in appearance. Right. And sir, the hair follicles in nevus depigmentosis, in vitiligo, we can see leukotrichia, and also the history, sir.
Plus the margins. Margins will be serrated.
Yes, sir. Serrated margins and nevus depigmentosis.
Hello, sir. Am I audible? Okay. Okay. So we are running a bit late, but we're going to start straight away with the award paper presentations. First up, we have our Dr. Anushka Majumdar, who will be presenting on dermoscopic findings in vitiligo with special emphasis on disease activity and observational study in a tertiary care center. I hope you all know the details, like you will be getting 7 minutes for the presentation. And since it will be presented from the technical end side, after each slide, please promptly say next, next, or next slide. Okay? Dr. Anushka Majumdar, kindly switch on your video. Dr. Anushka Majumdar, kindly unmute yourself. Dr. Anushka Majumdar, are you ready? Dr. Shruti Mondal, kindly mute yourself. Dr. Pranjal Pradeep, please mute yourself. Dr. Shaili Banerjee, mute yourself. Anything the technical team, please help her out.
Dr. Pranjal Praveen, please switch off your video.
If Anushka is unable to do it,
Pranjal.
Stopped, ma'am. I stopped the video, ma'am.
Okay.
Hello. Hello, am I audible? I'm
Yes,
asking,
you're audible.
okay. I'm asking the technical team if Dr. Anushka Majumdar is unable to share, if is unable to present right now, then please move on to that of Dr. Pranjal Praveen.
Am I audible? Should
Yes,
I
please
start?
start. Please start.
Good morning, delegates. I am Pranjal Praveen, and I'll be presenting my study titled as Association of Metabolic Syndrome with Lichen Planus, a case-controlled study from a tertiary care hospital in Eastern India. Next slide, please. Lichen planus, as we all know it, is the most typical and best characterized lichenoid dermatosis. Lichenoid dermatosis are a group of disorders which are characterized by lymphocytic infiltrates at the dermoepidermal junction. There are many disorders such as lichen striatus, lichen nitidus, which are included along with lichen planus among lichenoid dermatosis. Lichen planus is an idiopathic inflammatory skin disease affecting the skin and the mucosa. It has a chronic course with relapses and periods of remission, as a classical autoimmune disease does. There are certain common sites for lichen planus, such as the flexors of the wrists, the forearms, the dorsum of the hands, the shins, and the presacral area, and includes the oral and the genital mucosa. Next slide, please. Metabolic syndrome, as we all know, is a cluster of risk factors that contribute potential risk factor to affect dyslipidemia, hypertension, hyperglycemia, and obesity. Next slide, please. Keeping this in mind, we decided to conduct a study to show the prevalence of metabolic syndrome in patients of lichen planus attending the dermatology OPD. And this slide, and also to show the association of metabolic syndrome with lichen planus. The study was conducted for a period of 1 year and was classical hospital-based case control study, taking 35 cases of LP and 35 age and sex matched controls, taking prior ethical clearance from them. Next slide, please. As we can already see that the patients of lichen planus of either age and sex were included in the study, and we excluded the patients who were unwilling to participate and patients already under the treatment for LP. Next slide, please. The parameters of our study were the anthropometric measurements, the BP measurements, the both systolic and the diastolic BP, the serum triglyceride and HDL estimation, and fasting blood sugar levels, which we took by taking blood samples from the patients on the first visit. Next slide, please. Here is the definition of metabolic syndrome given by the American Heart Association or the International Diabetes Federation. You can look at the definition of the metabolic syndrome. A statistical analysis was done on the MedCalc software version 20.009, and we used the chi-square analysis to chalk out the results of our study. Next slide, please. We come to results and analysis. The mean age of cases was 37 years plus minus standard deviation, and that of the controls was 38 years plus minus standard deviation. Sex ratio of the cases, male is to female, was 1.18:1. And we can clearly see that the patients of LP belong more to the rural background as compared to the urban background from the pie chart towards the left. And the right side of the pie chart shows the common LP cases we found in our study, namely the classical LP, the oral LP, and the lichen planus hypertrophicus. Next slide, please. We compared the results of the systolic as well as the diastolic BP to the cases and the controls, and cases had a higher systolic and diastolic BP than the controls, giving a statistically significant result with an odds ratio of 5.33 and 2.96 respectively. Next slide, please. Then we compared the serum triglycerides as well as the HDL levels, and we found that the triglyceride levels were elevated, whereas the HDL levels were reduced in cases as compared to controls, giving an odds ratio of 7.66 and 3.69 respectively. Next slide, please. The fasting blood sugar levels were also compared, and fasting blood sugar levels was found to be raised in cases as compared to controls, giving an odds ratio of 5.06, making it a statistically significant result. Next slide, please. Waist circumference followed the same trend, and odds ratio was 4.07, giving a statistically significant result. Next slide, please. Now we compared the metabolic syndrome as a whole, and we found that features of metabolic syndrome were present in 21 out of 35 patients in our study, making it a prevalence of 60%, an odds ratio of 6, which showed that the metabolic syndrome was 6 times more common in patients of lichen planus as compared to that of the general population. Next slide, please. Next slide, please. Yeah. The previous one. The discussion of our study. The prevalence of metabolic syndrome as in our study was 60%, which was much lower as compared to higher as compared to Bakel et al., who pointed it to be 26.6%. But Saleh et al., 70% was much higher as compared to this. We give a take-home message that all the features of metabolic syndrome are more common in lichen planus as compared to other general population, and we advise regular screening and lifestyle and behavioral modifications to the patients. Next slide, please. The limitations were that the size of the sample was quite less, and so no significant association could be made. And study doesn't take into consideration the patients already having metabolic syndrome before the onset of LP. These are my references. Next slide, please. Thank you.
Thank you for your presentation, Pranjal.
Thank you,
Sir, I'm asking the judges. Okay, sir. Any questions, sir? Sir, Shamanta, sir, kindly unmute yourself. So you're muted,
Right.
sir. Okay, sir. Thank you. Sir.
Yeah, that was an
morning,
interesting presentation, Dr. Pranjal. Did you observe any typical features of the metabolic syndrome associated lichen planus in your cohort of patients?
Sorry, sir. Couldn't hear you, sir. Sorry.
Did you come across any specific features of lichen planus that is associated with metabolic syndrome?
The oral lichen planus was more common in those patients which I took in our study. Oral lichen planus are moreover more associated with metabolic syndrome as compared to the cutaneous features of lichen planus. Even some patients of nail LP, which actually we couldn't follow up those patients. They got chalked out of the study, but they were having more features of metabolic syndrome as compared to other patients of lichen planus in my study, as per 35 patients were concerned.
Can you explain the association between lichen planus and metabolic syndrome? How do you explain the association?
Yes, sir. So lichen planus is an idiopathic inflammatory dermatosis, and moreover, metabolic syndrome these days has come to the newer advanced concept of metabolic syndrome is that we find increased the inflammatory markers in these patients, such as CRP and ESR, CRP, TNF alpha. These markers are increased in the patients of metabolic syndrome as compared to that of the general population. And lichen planus, being an autoimmune disorder itself, leads to increase in these type of markers. And so a pathological correlation can be made between these type of patients, and such as other cases of other disease which carry metabolic, which also shows association between metabolic syndrome like psoriasis, have also increased such type of markers. So an association can be made.
Thank you. Thank you.
Thank you, sir.
Professor
Hello.
Ghosh, anything from your side, sir? Professor Ghosh? Okay. Sir, can we move on to our next speaker then?
Yes, please.
Okay, sure, sir. Pranjal,
Thank you,
please
Thank
mute
you, sir.
yourself. Our next speaker is Dr. Shairi Banerjee, who will be speaking on dermatosis in geriatric diabetic patients and their socio-economic profile, a clinico-demographic study in a tertiary care hospital in Eastern India. Dr. Shairi Banerjee, please.
On the first slide, so that everyone can see your CV. Just
technical team, please share the screen of Dr. Shairi Banerjee.
Do the other slides, the other slides about that you can show you. And you can do one more thing. You just send the your presentation to our technical team.
Olympia, madam, please mute yourself. Okay. Shairi, you may please start.
Okay. Good morning, respected delegates. I am Dr. Shairi Banerjee, and my topic is on dermatosis in geriatric diabetic patients and their socioeconomic profile, a clinico-demographic study in a tertiary care hospital in Eastern India. Next slide, please.
Technical team, please keep
the diabetes is a
timer ready.
Major health concern for the geriatric Ma'am, should I continue?
Please continue.
We are very well aware that diabetes mellitus is a major health concern in around the globe, and it has various dermatological manifestations, especially in the elderly. And it is very important that we recognize the symptoms at the very earliest and try to treat them to prevent further complications and to also improve their quality of life. We have also noticed that socioeconomic factors play a very important role in terms of nutrition, health care, wound care. So differences in the socioeconomic status can cause disparity in the dermatological. Next, my main aims and objective was to assess the dermatological manifestation in the geriatric diabetic patients and to also explore. Now we're having a lot of problems with the technical team, I guess. I'll just start with the aim.
Please continue.
The aim and objective was to assess the dermatological manifestations in the geriatric diabetic patients and to explore their association with socioeconomic profile. Next slide. It was an institutional-based observational cross-sectional study of 8 months in the dermatology OPD of Tertiary Care Hospital in Eastern India. Every consecutive patient aged more than 60 years who are known documented diabetics or under medication and have been advised to take medication are included for the study and of course willing to participate. Those who could not provide documentation or are under other systemic medications or immunosuppressants and unwilling to participate were excluded. Next. History included the duration of the disease, the time of appearance of the first dermatological symptom or sign, lifestyle habits, compliance to diabetic medications, their attendance at diabetic clinics. Socioeconomic status was calculated according to the modified Kupuswamy scale, keeping in mind 3 parameters: the occupation of the head of the family, the education of the head of the family, and the monthly income of the family. Clinical examination included all the relevant cutaneous and systemic examinations. KOH mount, Zank smear, pus stain culture, and biopsy were done wherever required. Next. Coming to results, out of a total of 150 patients, male is to female ratio is 0.7:1. I have included the lower class as lower and upper lower class of modified Kupuswamy scale, score ranging from 3 to 10. Middle class was included as lower middle plus upper middle, score 11 to 25, and upper class was scored from 26 to 29. Excuse me, madam. And this pie chart is not being shown. Technical team, please see to it.
Slides are there.
Shadi, please carry on.
Ma'am, pie chart to puro ma'am pie chart দেখাচ্ছে না আমার সব percentage গুলো দেখাচ্ছে না
Carry on.
Okay. The lower class was 71 patients. Middle class included 49 patients and upper class included 30 patients. Next, we noticed that the non-infective dermatosis was more common than the infective dermatosis. Xerosis involved the vast majority. It followed by pigmented purpura and others like acanthosis nigricans, sheen spots, acropordons, etc. There was no vast difference between the socioeconomic strata, at least amongst the non-infective dermatosis. Next, please. Amongst the infective dermatosis, bacterial infection and fungal infection comprise the vast majority, followed by parasitic and viral. As you can see from the pie charts, the maximum number of patients having the fungal and bacterial infections belonged to the lower class, followed by the middle class and upper class. Next. Amongst the non-infective dermatosis, perforating dermatosis and diabetic foot syndrome was more observed amongst the lower class, while eruptive xanthoma, insulin site lipodystrophy, and oral drug-related side effects were more amongst the upper class. Next. I also noticed that the participants living alone suffered more from xerosis and infections compared to other category. Next. I searched the literature and I found some similar results where Bachman et al. Found that diabetic patients were less educated and earned less, bear a larger burden of morbidity. Nader et al. Concluded that there are significant differences in the socioeconomic factors between diabetic patients with and without diabetic foot problems. And Joshua and Bregman also inferred that poverty, lack of quality education, and lack of healthcare had significant impacts. Next slide. So I've already discussed the study in a nutshell. Non-infective dermatosis were more common than infective, and they were more or less equally prevalent amongst all. Infective dermatosis, mainly fungal and bacterial, were more common in the low socioeconomic class. Fungal infections in the form of dermatophytosis, candidiasis, onychomycosis were more common, and bacterial infections in the form of folliculitis, furunculosis, cellulitis, diabetic foot ulcers were more common, and patients living alone suffered more from xerosis with pruritus. Next slide. Next, please. So we take home a message that though adequate healthcare is accessible to all, the lower economic strata seem to suffer more from the complications, and not due to their economic constraints, their transport charges, hygiene, malnutrition, wound care, clinics, loss to follow-up and input of medications. Next, please share the next slide.
I think Dr. Shairi Banerjee got logged out again. Some network issues, it seems.
Ma'am, am I audible? Hello?
Yes, ma'am, you are audible.
Am I audible?
Yes, you're audible. Continue.
Okay, ma'am. This study should help to bring in some awareness about the recognition of early and late skin changes in diabetics, especially in the geriatrics, understand the importance of lifestyle modifications on their health, and stress on the need to look after the geriatric diabetic population to prevent complications and also improve their quality of life. Limited number of patients and also limited amount of time were the limitations of the study. Next. Next slide.
Okay, thank you, Shairi. Sir, is there any questions from your side?
I would just like to ask one question. Yes, sir. Go ahead, please, sir.
No, yes. Dr. Badua, you can tell. Okay. Hello.
Sir, you go ahead, sir, please.
Oh,
right, sir.
Now, you told that in that uncommon dermatosis in this diabetic group, in the lower class more common are perforating dermatosis, but upper class more conductive xanthomas. So how can we explain that?
Shall you repeat the question?
Will I
Sir, can you
repeat?
please repeat?
Will I
Yes, sir,
repeat?
please.
Will I
Yes, sir,
repeat?
please repeat. Yes, sir.
You told that among the uncommon dermatosis,
Yes, sir.
and this lower class more common as the perforating dermatosis, and this upper class more common are eruptive xanthomas, etc. So how
Yes,
can
sir.
we explain this?
So, according to my knowledge, I noticed that the upper strata, they suffered more from hyperlipidemia too, and due to their less physical exercise, lifestyle, intake of more fatty foods and all, they had more deposition of fat and cholesterol. So that might explain the prevalence of xanthoma more in the upper class, and amongst the lower class, they due to their financial constraints, they suffered more from the renal complications. Like they had increased urea creatinine level in their blood, so that might, and also in poor wound care. So pruritus too. Like it can also lead to eruptive perforating dermatosis. So that might explain eruptive xanthoma more in the lower class.
Actually, this acquired perforatic dermatosis are usually late condition when
Late
already the
conditions.
renal pathology started. And
Yes, sir.
usually this lower economic class, they are usually always late in treatment.
Yes,
So
sir.
they come always the late stage. So we get more number of perforating dermatosis.
Right.
Okay,
sir,
thank
right,
you.
sir.
Thank you.
Thank
Okay,
you, sir.
Dr. Bodua, you can ask.
Oh, fine, sir. You actually asked part of my question, sir. But anyway, right, sir. That's okay. Fine, sir.
Okay, sir. Thank you, sir.
With your permission, I would like to move on to the next speaker. Thank you, sir. Thank you, Shairi. Our next speaker is Dr. Shiladitya Choudhury, who will be speaking on histological variants of seborrheic keratosis, a histopathological study in a tertiary care hospital in eastern India. Dr. Shiladitya Choudhury, please unmute yourself and start your video. Dr. Shiladitya Choudhury.
Yes, ma'am.
Okay.
Shall I start, ma'am?
Please start.
Good morning, dear delegates and my respected teachers. Today, I will be presenting the histological variants of seborrheic keratosis, which is a histopathological study in a tertiary care hospital in eastern India. This work has neither been presented or published elsewhere with no conflict of interest. Next slide. Seborrheic keratosis, as we know, they are the most common benign epidermal tumors of the skin, which can appear anywhere on the body, most frequently being the sun-exposed areas, mainly the face and the upper trunk. They begin as well-circumscribed, dull, flat patches, and they gradually increase in the height and depth, taking on more of a papular and a stuck-on appearance. From histology, we know there are 5 major histopathological variants: acanthotic, hyperkeratotic, adenoid, irritated, and clonal. Among all the histological variants, the common features in the histopathology would include hyperkeratosis or surface keratinization, acanthosis or widening of the retiridges, retipex, and papillomatosis with papillary projections. Pigmentation is often seen, the basal layer is often seen with acanthotic and adenoid types. Next slide. Moderate papillomatosis, hyperkeratosis with characteristic horn cysts or pseudocysts will be seen more in acanthotic variety, pronounced papillomatosis in hyperkeratotic, double rows of basaloid epidermal cells with fine branching of the epidermis into the dermis would be seen in adenoid variety. In the irritated, as the name suggests, we would find inflammation, lichenoid infiltration in the dermis with squamous eddies, suggesting increased epithelial turnover, increased keratinization. Now, the main rationale of our study was, since there is dearth of the studies on seborrheic keratosis done in eastern India, hence this study was done in order to find out more about this disease and see it from the histopathological perspective. The aim was to study the various histological types and to search for any features of malignancy if present. Next slide. The materials, this was an institution-based descriptive cross-sectional study done in a tertiary care hospital in Medical College, outpatient department. Based on the previous medical records and previous studies, 80 consecutive patients attending the OPD were taken in for the study. There were a detailed history was done along with clinical examination. Then they were subjected to biopsies. From the biopsies, the slides were reviewed and the salient features were noted. All patients above the age of 18 years were taken into study, whereas non-consenting, immunocompromised pregnant women with non-bleeding disorders were excluded from the study. Next slide, please. Among the results and the analysis, what we found, there were 42 males and 38 females included in the study. The average age was around 54 years, ranging from 32 to 78 years. The size ranged from 0.3 centimeters to 3 centimeters with a mean maximum diameter of about 0.9 centimeters. Dermatosis papulosa nigra was the most common clinical type, whereas the most common site involved was the face and the neck, as shown from the chart. Next slide, please. Among the histopathology done in the 80 slides, 3 of those slides showed non-corroborative or non-specific features. 77 of them showed corroborative findings. Among them, 58 of them, the highest number was shown to have hyperkeratotic variety, followed by the acanthotic variety of keratosis. Next slide, please. These are some of the pictures of acanthotic variety and the hyperkeratotic variety, which I have found in my study. Next slide, please. Among the others, adenoid type accounted for 4, irritated 2, and clonal was 1 of the variety was found among the 80 slides, as shown in the pictures in the given below. Next slide, please. Now, among those slides, some of the special findings have been found. 2 of the slides showed pigment incontinence, wherein there was pigment into the dermis. 2 of the slides, one of them, the morphological figure is shown below. They showed loss of melanin at the basal layer, which is normally seen in some of the specimens. Here, there is clear-cut loss of the melanin deposition in the basal layer. Next slide, please. Another one of the variety showed of the hyperkeratotic pattern, they showed focal acantholytic changes in the epidermis, as shown in both 100 magnification and in 400 magnification. Along with acantholytic changes, there also appear to be nests of epithelial cells in the stratum spinosum with acanthosis, mimicking that of Bors-Jadasson phenomenon. Next slide, please. And one special finding which we found in one of the slides is they had acanthotic variety. Along with that, there was a syringoid pattern. There was epidermal acanthosis with keratin pearls. Along with that, with keratin cysts, along with that, multiple branching ductal and tubular structures were seen in the epidermis. This is one of the special findings which I have found in my patient in one of the slides. Next slide, please. Now, from the results and the analysis, the discussion comes. Among the most common age group of seborrheic keratosis in other studies conducted by Rowe and Roque et al., the common age group was 19 to 98 years, wherein in my case, it was 32 to 78 years. The most common site of biopsy was the same in both my and as well as in Roque et al. Study, that is the head and neck region. However, the most common histological variant was acanthotic type in Hafner, in studies like Hafner et al. In my case, it was hyperkeratotic variety, and the pigmentation in the basal layer, it's seen in both acanthotic and adenoid types, as is shown in my study as well as in other studies like Fulari et al. Next slide, please. From the study, some take-home points and conclusion is the hyperkeratotic type has been the most common histological variant, and from the biopsies, we see none of the slides show any transformation, thereby concluding the fact that seborrheic keratosis is mostly a benign tumor. Limitation, the sample size in my study was small, and hence larger sample size and follow-up of the patients would be necessary in the near future for studying better study of this condition. Thank you. Thank you, ma'am.
Thank you, Sheila Ditto, for the presentation. Professor Ghosh, Professor Bono, would you like to ask him any questions? Hello, judges, am I audible?
Yes,
You're
yes, you are
audible.
audible. Yeah, I think we can go ahead. Thanks for the
Okay.
presentation, Dr. Shiladitya. Yeah.
Thank you,
Okay.
sir.
So with your permission, I would like to move on to the next speaker. Our next speaker is Dr. Shishir Dash, who will be speaking on metabolic syndrome among patients with early onset androgenetic alopecia, a cross-sectional study from a tertiary care hospital in Eastern India. Dr. Shishir Dash.
Hello, ma'am. Am I audible?
Yes, you're audible. Please start.
Okay. Greetings to respected chairperson, esteemed judges, and my dear colleagues. I am Dr. Shishir Das, presenting my research work titled Metabolic Syndrome among Patients with Early Onset Androgenetic Alopecia, a cross-sectional study from a tertiary care hospital in Eastern India. Next. As we all know, androgenetic alopecia is the commonest form of hair loss with adverse psychosocial impact. It starts post-puberty and progresses with age, whereas metabolic syndrome, which is a constellation of metabolic abnormalities promoting cardiovascular morbidity, diabetes, and its related complications, is rarely seen in the youth, that is 15 to 30 years of age group. Next. We designed this study with the objective of estimating the occurrence of components of metabolic syndrome along with clinical demographical patterns of androgenetic alopecia in 15 to 30 years of age. Next. We conducted a cross-sectional observational study spanning 1 year of on consecutive males and females in 15 to 30 years age group with clinically diagnosed androgenetic alopecia of cosmetically significant severity. Our exclusion criteria were formulated to reduce the effects of confounders on metabolic abnormality. Our estimated sample size was 50, calculated using appropriate formula. Next. Androgenetic alopecia severity was graded using Norwood-Hamilton classification scale for males and Sinclair scale for females. Metabolic syndrome was diagnosed according to National Cholesterol Education Program Adult Treatment Protocol 3 guidelines on presence of 3 or more abnormalities such as central obesity, hypertriglyceridemia, low HDL levels, impaired fasting glucose, and raised blood pressure. Anthropometric, clinical, and appropriate biochemical parameters were recorded in all patients. Data was analyzed using appropriate statistical tools, and results were compared against available literature. Next. During the study period, total 122 cases of androgenetic alopecia in 15 to 30 years age group were evaluated, among which 41 did not consent to be included, and 27 were found ineligible based on exclusion criteria. The remaining 54 subjects were recruited in our study. Next. So our study population comprised of greater proportion of males, among them 56.25% were from rural West Bengal, mostly belonging to the lower middle class strata. In contrast, 81% of female participants were from the urban areas and mostly from the upper middle class background. Next. 70.4% of the study subjects have positive family history of androgenetic alopecia with mostly paternal inheritance, and almost half the participants had family history of hypertension and ischemic heart disease or stroke. Diabetes mellitus was prevalent among 30%. Menstrual irregularity and hirsutism was present among 40.9% and 31.8% females respectively. Sedentarism was prevalent among 74.1% of participants. Next. The age and gender-wise distribution suggests that probability of detecting at least one component of metabolic syndrome increases with age, with slight female preponderance. Next. The subjects were stratified into 3 groups each based on severity and duration of androgenetic alopecia. The frequency of detecting raised blood pressure, represented by the green bars on the left, increased with both severity, and on the right with duration. Frequency of detecting metabolic syndrome, which is represented by red bars, had no relation to the severity but were positively related with the duration of the disease. Next. As per the chart on the left, the mean values of body mass index represented by light blue bar, waist circumference by deep blue bar, and triglyceride level with a yellow line. They show increase with the duration of androgenetic alopecia. On the right, the chart shows low HDL level was the most frequent abnormality detected, followed by hypertriglyceridemia among these participants. Next. Upon extensive search on PubMed and Google Scholar, we could not find enough data on Eastern population, Eastern Indian population. In our study, the highest frequency of metabolic syndrome was observed among 26 to 30 years age group, and with female preponderance similar to findings of E et al. Next. So this is a literature comparison table with highlighted significant deviations. The frequency of metabolic syndrome in our study population was 12.96%, similar to findings of Sheikh Fatima Zia et al. But this was significantly lower than observed by Kumar et al. And Chakraborty et al., which may be explained by the ethnic variations and dietary habits. The mean diastolic blood pressure in our study was 79.17, standard deviation 6.22, which is significantly lower than reports by Banger et al. And Chakraborty et al. Mean triglyceride level was 139.78, standard deviation 70.73, similar to other authors except Chakraborty et al. Mean fasting blood sugar was 88.98, standard deviation 10.13 in our study, in contrast to Banger et al., who reported a mean of 96.21 with high standard deviation over 30. Next. So low HDL was the most frequent abnormality at 48.1% found in our study subjects, similar to findings of Su et al. The limitations of our study includes a relatively small sample size, and being a hospital-based study, the study sample may not be a true representative of this community. So next, to conclude our study, in our study, occurrence of metabolic syndrome was higher among early onset androgenetic alopecia patients, and the prevalence was significantly lower than previous studies conducted on similar age-sex matched populations. And in this study, we would like to emphasize that early screening for metabolic syndrome in early onset androgenetic alopecia may prevent serious cardiovascular comorbidities in the future. Thank you. These are my references.
Okay. Thank you, Dr. Shishir. That was a very good presentation.
Thank you.
I would like to ask the judges if they would ask a question, if they would like to ask a question to Dr. Shishir.
It's okay for me. It's okay.
Okay, sir. Professor Borua?
Yeah, I'd just like to know from Dr. Shishir is, did you note any difference in the prevalence of metabolic syndrome in the general population and the cohort of early AGA?
Sir, ours was a descriptive study. We did not recruit any controls. So we compared our findings with the other literature where they had a case and control arm. We compared with the cases, and we took a general data from a population-based study in whole of India done by JAPI, the expert control committee, the expert consensus committee, and we found that in the similar age group, the prevalence of metabolic syndrome was around 3 to 6%, depending on areas.
Okay, fine. Thank you.
Okay, sir. I would like to move on to our next participant, or next speaker is Dr. Sudip Mondol, who will be speaking on attitudes and perception of undergraduate students to online dermatology classes during COVID-19 pandemic, a cross-sectional pilot study from Eastern India. Dr. Sudip, please unmute.
Am I audible?
Yes, you're audible. Please switch on your video.
Good morning, everyone. I, Dr. Sudip Mondol, will present my study titled Attitudes and Perceptions of Undergraduate Students to Online Dermatology Classes During COVID-19 Pandemic, a cross-sectional pilot study from Eastern India. Next. In the wake of COVID-19 pandemic, most countries imposed lockdown and converted traditional classroom teaching into distance education. As we all know, dermatology has always been a fairly neglected subject among the final year MBBS students. In our final year MBBS university examination, out of total 900 marks, only about 2% marks is allotted for dermatology. So MBBS students are not incentivized to attend dermatology classes online in their undergraduate days. Next slide. The lockdown in India started in March 2020. The traditional classroom and bedside teachings of MBBS students came to a halt. Technologically enhanced approaches has already been proven to have high levels of engagement with medical students. Final year MBBS students of the batch 2021 to 2022 were presented with an opportunity to attend online lecture classes in dermatology during this period of time. Next. So we set out to do the study with the aim to assess the impact of online dermatology classes on final year MBBS students during this COVID-19 pandemic era. Next slide. Now coming to the methodology of the study was an institution-based multimodal cross-sectional pilot survey undertaken among the final year MBBS students. Ethical clearance was taken for the study. Willing final year MBBS students of our institute who have attended at least one online dermatology class were included. The unwilling final year MBBS students, who did not attend any online dermatology class, and final year MBBS students who could not be contacted during the study period were excluded from the study. Next. Now coming to the study procedure. Next slide. Now coming to the study procedure. From the online class logs, we found that 68 students attended online dermatology class. Among them, 11 students could not be contacted and 6 students did not study. 51 remaining eligible consenting participants. Previous slide. Participants received the paper-based version of the questionnaire. Then one day after returning the questionnaire, they received the same questionnaire in web-based form. Self-reporting of both questionnaires was done by the students. Then we matched the data of both questionnaires. 9 entries were discarded due to data disparity, and finally 42 entries were selected for data analysis. Next slide. This is the questionnaire that I used for data collection. Next slide. Now coming to methods of data collection, the multimodal survey included both web-based and paper-based questionnaires. Validation of the questionnaire was done using phase validation, and its internal consistency was authenticated as the Cronbach's alpha was found to be 0.62. Class attendance data was collected from the records. Collected data from 2 modalities were matched based on the unique ID of the 2 questionnaires, and recorded data was tabulated in Microsoft Excel and analyzed using statistical software SPSS version 20. Next slide. Now coming to the results, the ratio of male to female participants was 1.33:1. Before the pandemic, average attendance of traditional classroom was only 12%. This data was collected by computing the attendance records of previous 3 years of traditional classes. But during online classes, at the time of pandemic, the attendance was around 47%. So there was around 300% increase in the class attendance, which was really astonishing. Next slide. 59% students chose live online classes as the most effective method of learning dermatology online, followed by 29% students who felt that video tutorials was the most effective method. When students were asked if online classes were interactive or not, 40% responded mostly yes, and 17% responded yes. So a total 57% students marked favorable responses. Next. When I tried to look for any association between study hour per week and online classes being interactive, I found that there was a definite positive, though weak, correlation between study hour per week with classes being interactive. Next slide. In a multi-option question, when the students were asked about the challenges faced during online dermatology classes, 30 responses were in form of lack of hands-on training, followed by problems in internet connection, 27 responses. Other responses were family distractions, timing of tutorials, and lack of device. But even with all the obstacles faced, the aspect of online dermatology classes that the students enjoyed were the ability to see vivid images of the diseases, followed by opportunity to attend classes from residents, interactive classes, and scope of asking questions. Next, interestingly, our research shows online learning in dermatology is different from learning other undergraduate subjects online, according to 79% of the students. When he searched for the reason, 37 respondents informed that they were interested in dermatology online classes as they were image specific in nature. 21 participants felt that there was no need of detailed clinical examination of the patients. 15 students felt that dermatology teachers were good. And interestingly, 14 participants felt that there was that many dermatological diseases could be learned over a very short period of time. Next slide. So armed with these results and analysis, I come to my discussion. Here I want to say, though majority of the participants felt that online classes are not sufficient enough to learn dermatology completely, but the image specific nature of the subject dermatology made it an interesting subject among the final year MBBS students. So I want to conclude my discussion by stating that online dermatology classes can be introduced by respective college authorities to uplift the status of this subject among the undergraduate students. Yes, there are a few limitations in my study, chief among them being small sample size and lack of any previous data on this very specific topic, averting any comparison. Yet, I live with the hope that my presentation will somehow help to imbibe great interest in dermatology among the undergraduate students in days to come. Next slide. These are the very few references I found for my study. Thank you.
Thank you, Dr. Sudeep, for a most interesting study with a lot of insightful observations. So what I would like to know from you is, Dr. Sudeep, what measures would you recommend to make online dermatology classes more interactive and more attractive for our final year MBBS students?
Sir, we can introduce hybrid methods of learning where both simultaneously few classes can be online and few classes can be offline. That may be helpful in nature. And the chance of interacting with teachers online, that is a very restricting part of online classes that if we able to do may make the classes more interesting for the final year students.
Okay, thank you.
Thank you, sir.
If sir doesn't have a question, can we go ahead?
Hello.
Yes.
Yes.
Hello.
I want to ask you, do you think that the present teachers were not much accustomed to this online teachings or other? Do you think that they should be more trained on this particular aspect, these online classes and others, to make it more interesting and more interactions and more informative for the students? Do you think so?
Sir, I hope that if the students are attending classes on their respective devices, that they're available readily from in form of smartphones or laptops, the images of the diseases that are mostly prevalent in dermatology can be seen properly. In traditional classes, many students feel lag to come to online the classroom because the very few marks is allotted for dermatology in final year MBBS examination. If the marks can be increased in final year MBBS examination, maybe there will be more incentive to attend classes online in this subject.
But do you think these teachers should have more training for this online classes? They should have more training because they are always not very accustomed for this type of online teaching. No, I'm talking about the teachers.
Yes, sir. This is a very new mode of teaching method that is has been forced to us because of this pandemic. But this is helping everyone to learn new ways of teaching the subject. With proper training, teachers maybe also be thinking of making the class more interesting for the students.
Yes. Okay. Thank you. Thank you.
Thank you, sir.
Dr. Sudhir. Thank you, sir. With your permission, I would like to ask Dr. Supratim Karmakar to present his paper on pigmentary demarcation lines on face and observational study in a tertiary care center in Eastern India. Dr. Supratim Karmakar.
Thank you, ma'am. May I start?
Yes, please start. Please start.
Good morning, everyone. Good morning, respected judges. Myself, Dr. Supratim Karmakar. I'm going to present a paper on the pigmentary demarcation lines on face and observational study in a tertiary care center in Eastern India. Next. Pigmentary demarcation lines, also known as Kucher's lines or Voigt's lines, are physiological abrupt transition lines from areas of deeper pigmentation to the area of lesser pigmentation, seen mainly over the limbs, the face, and sometimes the trunk. Pigmentary demarcation lines are physiological entities. Hence, they are often considered an atavistic remnant where the dorsal skin is pigmented more than the ventral one, thereby providing better protection from the sun, thereby reflecting the normal patterns of embryological hyperpigmentation on the face of the humans. PDLs, especially here in this study, will be focusing on the facial PDLs, the type F, the type G, and the type H. The type F is a V-shaped linear hyperpigmentation on the lateral aspect of the cheek. Type G is W-shaped similar hyperpigmentation on the lateral aspect of the cheek, while the type H is a linear hyperpigmentation from the angle of the mouth to the lateral aspect of the chin. These facial PDLs represent the patterns of facial pigmentation and closely correspond to the Blaschko's line over the face. Now, why this study was taken up? Because there was a dearth on the study of human population with facial PDL. Next slide, please. My aim was to find out the pattern and frequency of PDL in face among the patients attending the skin OPD of a tertiary care center, and also to find out the demographic parameters of patients having facial PDL. Next slide, please. My study was conducted in the OPD of Dermatology, Venereology, and Leprosy of Medical College and Hospital, Kolkata, where all the patients with facial pigmentation as per the inclusion criteria during the study period were included in the study, which was conducted over a period of 15 months starting from January of 2020 to March of 2021, where 42 patients were included in the study. Here, all patients of all ages and genders with a linear hyperpigmentation who gave written informed consent were included into the study. However, patients with post-inflammatory hyperpigmentation, maturation dyschromia, and melasma were excluded from the study. It was an observational, descriptive, institution-based cross-sectional study. Next slide, please. This is a roadmap of my study where all patients with facial pigmentation attending the OPD of Dermatology Department of MCH were included if they gave an informed consent, following which detailed history, thorough clinical examination, relevant investigations, and data collection was done, followed by statistical analysis. There are other patients who were not included in the study who did not give consent. Next slide, please. Coming to results and analysis, the mean age of the patients who were included in this study were 29.5, where most of the patients were in the 4th decade. The females outnumbered the males in the ratio of 13:1. Next slide, please. Out of 42 patients, most were housewives, followed by students who were 19%. Next slide, please. The duration of PDL ranged from 6 months to 15 years with a mean of 5.2 years, and most patients had a duration which is less than 5 years. Next slide, please. The most common site involved of PDL was zygomatic, followed by zygomatic plus mandibular, which was 33.3%. Next slide, please. Out of 42 patients, only approximately 27 of the patients gave us a positive family history. However, the rest patients, they gave no such family history. Next slide, please. The most common type of PDL was type G, while the least common type was type H, which was approximately 5%. Next slide, please. Coming to discussion. In a previous study by Anthony et al., most of the patients were above 18 years. Similar study by Dr. Somani done in the year 2000. We also found out that all patients had an onset around puberty. In our present study, the age group ranged from 12 years to 52 years, with the mean age being 29.5 years, while most of the patients were in the 3rd decade. James et al. Reported that in Caucasians, PDL was most common in women rather than the men. In a study by Dr. Somani, out of 243 patients who he studied, only 9 were males and 234 were females. Similar observations were found by Dr. Malakar, where he also found that mostly females presented with PDL-like lesions. In our study, there was a preponderance of females over males. Next slide, please. Family history varies from 61% in a study by Dr. Somani to 35% in a study by Samari et al. On Saudi Arabian patients. Similar observations were also found by Anthony et al., who found that only 2% of the patients had a family history. However, patients cannot be relied for diagnosing PDLs in their relatives, and this could account for the variation seen. In our study, out of 42 patients, only 26.2% of the patients gave positive family history, while the rest, almost 74% of the patients gave no such history. Dr. Somani found that group F was the most common type of PDL that was found. Similar observations were also made by Anthony et al. But in this study, we found that the most common type of PDL was type G. Next slide, please. On the left, there are a few pictures of the patients which I have included in my study. On the left are the type F PDL. On the right are those patients who have presented with type G. Next slide, please. To conclude, female patients, mostly housewives in their 4th decade, comprise the bulk of patients presenting with facial PDL. Since PDL is mainly asymptomatic, cosmetic reason is the primary concern. We also found that facial PDL doesn't run in the family, where type G is the most common finding. However, this finding differs from other studies where type F is the most common. Here are a few limitations that only 42 patients were included in my study. However, a more extensive study with a greater sample size is required. Correlation with metabolic profile and hormonal analysis was not done. Dermoscopy and histopathology were also not done. Next slide, please. Here are a few references. Thank you, everyone.
Thank you, Supati, for your presentation. I would like to ask the judges, Professor Ghosh and Professor Barua, if they would want to ask any question.
Okay, it's okay for me.
Yeah, we can go ahead. Thank you.
Okay, sir. Thank you, sir. So we next go to our presentation by Dr. Anushka Majumdar. She will be presenting on dermoscopic findings in vitiligo with special emphasis on disease activity and observational study in a tertiary care center.
Thank you.
Thank you, sir.
Thank you, judges. Thank you, Anushka. So we will move on to our next presentation by Dr. Madhav Datta. He will be speaking on clinico-demographical profile of Blaschkoid dermatosis, a descriptive cross-sectional study from a tertiary care hospital in Eastern India. Dr. Madhav?
Yes, ma'am. Am I audible?
Yes, you're audible. You can start now.
Good morning, honorable judges, respected teachers, and my fellow colleagues. I am Dr. Madhav Datta, final year PGT. Today, my topic of presentation is clinico-demographical profile of Blaschkoid dermatosis, a descriptive cross-sectional study from a tertiary care hospital in Eastern India. Next slide, please. The concept of Blaschko's line was first put forth in 1901 by Dr. Alfred Blaschko. These lines probably represent the roots of ectodermal cell migration from the neural crest. Many different nevoid and aqua dermatosis on the skin follow the pattern along the lines of Blaschko. Next slide, please. Our study is a descriptive observational institution-based cross-sectional study done in a tertiary care hospital of Kolkata over a period of 1 year after obtaining permission from the Institutional Ethics Committee. Our estimated sample size was 50 according to the formula. Every consecutive consenting patient of all age groups attending the OPD having skin lesion along the lines of Blaschko was included in our study. Relevant history was taken, detailed clinical examination, and appropriate laboratory evaluation were done. These data were compiled and statistical analysis was done using GraphPad Prism version 5 software and Microsoft Excel. Next slide, please. In our total study population, that is among 59 patients, most of the patients presented in between 6 to 15 years of age, and the least common age of presentation is more than 50 years of age. Our study shows slight female preponderance, that is 61.02% were female and 38.98% were male. Next slide, please. Among the study population, 62.71% were from rural area, which is shown in the left bar diagram, and 57.60% were Hindu, which is shown in the right pie diagram. Next slide, please. According to the modified Kupuswamy scale, the most common socioeconomic class was lower middle, followed by upper lower class. Next slide, please. In our study population of 59 patients, 19 patients, the onset was since birth, followed by in 14 patients, it was between 0 to 5 years of age, and only a single patient had onset after 50 years. Only 2 patients had positive family history, whereas in rest of the 57 patients, it was negative. Next slide, please. In our study population, most common clinical sign was itching, followed by scaling, and then hypopigmentation. And the least common clinical sign was formation of blister and malodor. Next slide, please. In the whole study population of 59 patients, the upper limb was involved in 24 patients, followed by the involvement of the lower limb in 17 patients. And the perineum was involved only in a single patient. Next slide, please. Most of the cases were unilateral, with the right and the left side involved in 47.6% and 45.76% of the patient respectively. Bilateral involvement and involvement of the midline was present in 3.39% each. In the right pie diagram, it is shown that among 59 patients, the narrow band pattern, broad band pattern, and thyroid pattern were present in 53, 4, and 2 patients respectively. I have encountered no patients of checkerboard pattern, lateralization pattern, and patchy pattern without midline separation. Next slide, please. The left upper picture showing the pigmentary mosaicism with hypopigmentation on the left side of the chest and the left upper arm in a child. The upper right picture showing a verrucous epidermal nevus on the right side of abdomen in a 8-year male. The left lower picture showing a black square lichen planus on the left side of the abdomen in a 6-year male. And the right lower picture showing the nevus sebaceous on right pinna and neck in a 22-year male. Next slide, please. The most common dermatosis we have encountered in our study is lichen striatum, followed by verrucous epidermal nevus and black square lichen planus. Next slide, please. There is a depth of data regarding black square dermatosis in India. After thorough search in PubMed, we have found the following literature for comparison. Ma'am, previous slide. Previous slide. Okay, next one. In the study of lichen striatus by Zhang Wei et al., the mean age of presentation was 17.5 years, whereas in our study it is 9.4 years, and female to male ratio was 1.6:1, whereas in our study it is 4:1. In the study of black square lichen planus by Bologna et al., the mean age of onset was 33 years, and in our study it is 27.25 years. Male to female ratio was 0.3:1, whereas in our study it is 5:3. Next slide, please. Verrucous epidermal nevus most commonly involves neck and shoulder region in our study as compared to head and neck region with the study by Morin et al. We found 2 patients of nevus sebaceous. The right side of face was involved in both of them with narrowband pattern in concurrence with the literature review. Next slide, please. The study was limited by its relatively small sample size, and it is an institution-based study, so the result may not reflect the actual scenario of the whole population. To conclude, the Blaschko's line attributes the lines of migration and proliferation of epidermal cells using embryogenesis. The lichen striatus is one of the most common form of black square dermatosis, and in majority of the patients of black square dermatosis, the lesions are unilateral in distribution, involving the upper limb and narrowband pattern. Many of the black square dermatosis are associated with certain systemic involvement such as in niggard sebaceous or verrucous epidermal niggard. But in our study, after thorough examination, we have found no such systemic association amongst any of our patients. Next slide, please. Thank you.
Thank you, Madhav, for your presentation.
Thank you.
I would like to ask the judges if they want to ask any question.
Okay, it's okay for me. It's okay.
Thank you.
Professor Ghosh, sir, if you want to ask any question.
No, okay, okay, it's okay. It's okay.
That's fine. That's fine. Thank you.
Thank you.
So we have come to the end of the session. Our judges for the session were Professor Dr. Sanjay Ghosh, sir, and Professor Dr. Samantha Barua, sir. Thank you so much, sir, for being there for the session. We would like to next